All right, welcome. Today we are jumping right into a deep dive on otitis media. It's one of the most common things you'll see in clinical practice, and we're going to trace the entire journey from the patient's ear to the microbiology lab and all the way to a targeted treatment plan. Let's get started. So here's how we're going to break it all down. We'll start with a quick overview, then dig into how we actually identify the pathogen. From there, we'll talk about those pathogens and the huge issue of resistance, map out our antimicrobial strategies, look at what happens when things go wrong with complications, and finally, we'll cap it all off with a clinical challenge to bring it all home. Okay, first things first, we need to get on the same page. What exactly is otitis media, and what are the key distinctions we have to make right from the start? Because not all ear infections are created equal. On the surface, the definition is simple, right? Otitis media is just inflammation of the middle ear. But that simple term hides this whole spectrum of conditions, from acute to chronic. And understanding the difference between them is absolutely fundamental. And here's the single most important distinction. It all comes down to the eardrum. With acute otitis media, or AOM, you get this rapid onset of symptoms, usually after a cold or some other virus. And that eardrum is intact, but it's bulging. Now contrast that with chronic suppurative otitis media, or CSOM. This is where you have persistent drainage coming through a hole in the eardrum. That one fact, intact versus perforated, changes everything. The bugs are different, and the treatment approach is completely different. So let's follow that ear swab from the clinic into the lab. This is where the real detective work begins, with a very precise workflow designed to pinpoint exactly which bacteria is causing all the trouble. It all kicks off with getting a good, clean sample. Immediately, a gram stain gives us our first look under the microscope. What kind of bacteria are we seeing? How big is the inflammatory response? Then we plate that sample onto different kinds of agar and incubate it to grow whatever might be there, the easy stuff and the more picky bugs. And then the magic. We use incredibly fast techniques like MALDI-TOF mass spectrometry, which can literally give us a definitive species ID just minutes after we see growth. Okay, so we know how to find them, but what are we actually finding? Well, the microbiology of otitis media is really a tale of two different sets of bad guys, and it introduces the constant challenge of antimicrobial resistance. Now look at this. You can see this massive divide, right? For AOM, it's the classic respiratory pathogens, strep pneumoniae, H. flu, Moraxella, the usual suspects. But for CSOM, with that eardrum open to the outside world, it's a whole different ballgame. We see tough characters like Pseudomonas aeruginosus, Staph aureus, and a mix of anaerobes. Knowing this distinction is everything when you're choosing that first antibiotic. So, once we have a name for our culprit, we have to find its Achilles heel. The lab does this by figuring out the minimum inhibitory concentration, or MIC. It's basically the lowest dose of an antibiotic that will stop the bug in its tracks. We take that MIC value and compare it to official breakpoints. So for Pseudomonas, for example, if the ciprofloxacin MIC is above 0.5, that bug is considered resistant, and the drug is just not going to work. This data is the absolute foundation of smart, targeted therapy. So now we're armed with the bug's name and its rap sheet of weaknesses. With this intel, we can build a really smart antimicrobial strategy, moving from those broad guidelines to a treatment plan tailored for our specific patient. Guidelines give us our starting playbook. For a routine adult AOM, high-dose amoxicillin is the workhorse for 5 to 7 days. For CSOM, the game plan is totally different. We use topical antibiotic drops to get super high concentrations right where the infection is. But when things get really serious, like the infection spreads deep into the neck, we have to bring out the big guns. Aggressive IV therapy, often for 2 to 3 weeks, combining drugs to cover everything. And, we can't get this deep without at least one terrible joke. It's a bit corny, I know, but the message is solid. A targeted approach based on what the culture actually grows is always the way to go. Now, when our patient is a child, the rules change a bit. Amoxicillin is still a cornerstone for AOM, but in newborns, every dose is meticulously based on their weight, and we often start with broader coverage. And we absolutely cannot talk about this without mentioning vaccines. They have been a total game changer, dramatically cutting down how often we even see infections from two of our main culprits, strep pneumonia and Hib. Okay, this right here is a huge clinical pearl. So many patients have a penicillin allergy on their chart that follows them for life, and it really limits our best treatment options. But the evidence is so clear, most of those allergies just fade away. Think about that. After only 10 years, 80% of people with a proven allergy are no longer allergic. It's a powerful reason to always dig into that allergy history and maybe, just maybe, get rid of that label. Now, most ear infections get better, but we have to talk about what happens when they don't, when they escalate into something far more severe, and how we can control and prevent that from happening. This timeline is a sobering look at just how fast things can go wrong. An infection that starts in the middle ear can spread right next door into the mastoid bone. And from there, it is a very short trip into the skull, which can lead to catastrophic things like meningitis or a brain abscess. All the while, the bacteria can spill into the bloodstream and trigger sepsis. And when one of these awful complications does happen, treatment is a marathon. Take an invasive infection like Listeria meningitis. The absolute minimum course of IV antibiotics is 21 days, a full 3 weeks. This also becomes a public health issue. A simple ear infection isn't something you report. But if that bug gets into the blood or spinal fluid, then you bet it's reportable. And if that ear culture comes back with a multi-drug resistant organism, an MDRO like MRSA, that patient immediately goes into contact isolation. That means strict hand hygiene, gowns, gloves, everything we can do to stop that superbug from spreading. Okay, we have covered a ton of ground. So now let's put it all together and apply what we've learned to a clinical challenge. So here's the setup. You have a 65-year-old with CSOM, and they're getting worse, not better. The lab calls you, they've grown Pseudomonas aeruginosa. And here's the crucial data from the susceptibility report. The bug is resistant to ciprofloxacin, but it's susceptible to ceftazidime. So, what's your move? The only right answer here is to pivot. You stop the oral drug, and you start intravenous ceftazidime. And the why is driven entirely by the data. The lab is telling you ciprofloxacin is going to fail. And because the patient is getting worse, you have to worry about a deeper, more invasive infection. So you can't mess around. You have to hit it hard with a drug that you know is going to work. And that really brings us to our final big picture question. We have a good playbook, for sure, built on decades of evidence. But the bacteria themselves are changing the rules of the game on us, with resistance patterns shifting all the time. So the question we have to keep asking is this: are the tools and strategies we're using today going to be enough to handle the challenges of the next decade? It's a question that demands our constant vigilance.